Hi, and welcome to Virtua Health's Real Talk Women's Health Chat. I'm Nicole Michalik from 92.5 XTU, and I'm so excited as always to be your host for tonight's event. This is one of my favorite things to do, to learn and educate and bring women together and to feel good about themselves physically and mentally. It's just the best. So thank you so much for being here. So a few helpful hints for tonight's session. Your camera and microphone are turned off, but you can still ask our panelists questions through the Q&A tab. You can choose to submit questions anonymously, and our experts will answer your questions toward the end of the session. And a number of you have already submitted excellent questions for our experts when you registered, and we're going to incorporate many of them into the discussion. Now, if you prefer to have closed captions on, you're going to click the live transcript button at the bottom of your Zoom screen and then select Show Subtitle. You can adjust the size of the font by clicking Subtitle Settings. And you should see the closed captions at the bottom of your screen. Really easy. Okay, let's jump into it. I mean, talk about amazing panelists. So I'm pleased to introduce our experts for tonight's session: physical therapist Richard DeWitt, neurosurgeon Kyle Mueller, and spine orthopedic surgeon James Sanfilippo. Rich received his Bachelor of Arts degree in biology from Johns Hopkins University and his Doctor of Physical Therapy from Rutgers/UMD-NJ. He worked in outpatient orthopedic settings since 2013 and presents regular education for virtual colleagues on treatment of strategies for spine, shoulder, and lower quarter conditions. In his spare time, Rich enjoys reading, going to concerts, and relaxing with his cat. Dr. Mueller is a board-certified neurosurgeon and completed a residency in neurosurgery at Georgetown University Medical Center. He completed a fellowship in spine biomechanics research at MedStar Union Memorial Hospital in Baltimore and complex spine fellowship at Warren Alpert Medical School of Brown University and Rhode Island Hospital. Dr. Mueller enjoys hikes and brews and spending time with his wife and young son and dog, hazy like an IPA. Dr. Sanfilippo is a board-certified and fellowship-trained spine surgeon and received his medical degree from the University of Medicine and Dentistry of New Jersey. He completed his residency in orthopedic surgery at Thomas Jefferson University Hospital in Philadelphia and went through additional training for spine fellowship at Emory Orthopedics and Spine Hospital in Atlanta. Dr. Sanfilippo enjoys hiking with his family, traveling, and coaching baseball. Welcome, everyone. I mean, those credentials are nothing. Easy peasy. So thank you so much for being here, for doing this. This is really exciting. So we're going to jump right into it. So how do we know if the back pain we're experiencing is something that we need to see a specialist about? Dr. Sanfilippo, if you want to kick it off, and then we'll kind of go from there.
Sure. Well, first off, thank you for having me tonight. Back pain, and I'll throw neck pain in with this, is one of the leading causes of people going to seek out medical attention. And I will tell you, 25 million to 30 million people a year will miss work because of back or neck pain. With that, the vast majority of these are minor injuries, strains, sprains, things like that. And usually will get better after, a few days to even a week or two of rest, anti-inflammatories, ice, heating pad, those types of things. I will tell you there's a couple of red flags that we look for in sort of what we call these acute injuries or these, new onset injuries. Any pain that's going down an arm or pain that's going down a leg, any numbness or tingling, any weakness where you're having difficulty controlling your arm or controlling your hand, tripping over your foot or your knee buckling on you. Those are things I would tell you to seek out medical advice or medical treatment as quickly as possible for, either going through your primary care or going to an urgent care or even the emergency room, depending on the timing of the injury. But for the vast majority of these injuries, after a couple of days to even a week or two, if we're not getting better, that's when we really should seek out the medical attention that we need.
Yeah, I think it's important because so many people, like you said, they deal with back pain, they deal with neck pain, even shoulder pain. And there's two types. There's the chronic and then there's the acute. And it's trying to figure out, how long have I had this? Is it getting better? So do you recommend, you said like a 2-week kind of basis. And I guess if somebody has an injury, they know that it's acute, but I'm assuming somebody could have a chronic back pain that gets worse, so then it feels like an injury. Is that correct?
100%. We call that acute on chronic, or it's basically a flare up or an exacerbation of an existing issue.
Right.
It's the same thing. If if it's been a couple of days to even a week or so, and we're not seeing improvement with the normal treatments, right? The rest, the ice, the stretching, the Advil, Motrins, Aleve, Tylenols, then it's worth going to see. But again, everybody knows themselves better than any doctor is going to know you. So, if your pain is usually mild and doesn't really interfere with anything, but you get 3 or 4 days of pain that really just knocks you out, where you're having trouble getting out of bed or trouble getting off the couch, well, then it's worth getting it looked at. Something else may be going on at that point.
Yeah, absolutely. So let's talk a little bit more about the common back issues, specifically in women. So you have degenerative disc disease, you have herniated discs, and I also think that if you can elaborate a little bit, and all three of you can kind of jump in, because the hips are connected to the back, and women also tend to have some hip pelvic pain, and that could all be together. And so maybe just touch a little bit about that, about maybe like what women could look out for in regards to back pain, chronic pain, those kind of things. Who wants to jump in? Dr. Sanfilippo, why don't you start, and then you guys can both, Richard and Dr. Mueller, can kind of piggyback off that.
Yeah. So, one of the things that I will say specifically when it comes to women's health, you worry about some ligamentous laxity issues. You worry about some alignment, like you said, about hips and the pelvis and the spinal alignment, and how that leads into back pain, or possible predisposing for back pain or herniated discs. The common things that we look for are still the common things that we look for. We look for arthritis in the back, whether that's breaking down of the disc themselves, which sort of sits in front of the spine, or the joints that sit behind the spine. We worry about, if that leads to a little shift in the bones one way or the other, that can lead to back pain, or even a pinched nerve going down the leg. I will say, as we get older, and this is both male and female, but we do see this predominantly as a female issue when you look in the media, is osteoporosis. And you worry about, a mild injury causing a compression fracture, or something that will lead to back pain that way. So those still, I would say, are the vast majority of things that I see in my office that we help to treat, whether it's male or female. But you do worry about those anatomical differences leading to and predisposing to some back pain.
So would somebody come to see you, and then you would decide, okay, let's try physical therapy, or let's try surgery?
So really, in my practice, and I'm not going to speak for Dr. Mueller, but we work on just trying to get the patient in as quickly as possible. It's, access, whether it's to the surgeon, to the interventional pain management physician, to the non-operative provider. Let's get the patient in, let's get the x-rays, let's see what we're dealing with, then refer out to physical therapy if that's what's warranted, refer to the anti-inflammatories if that's what's warranted, and basically progress the patient and move them through the system. But patients can seek treatment through their primary care physicians, who can start to manage that initial. They can seek treatment directly from physical therapy. They can seek treatment through an urgent care. All of those pathways can get you started into that process as far as access points.
So, sorry, Dr. Mueller, go ahead.
Yeah, I was going to say, in similar fashion, a lot of times people are just wanting to kind of be seen and evaluated, and the vast majority of people, I would agree with, that show up at a surgical clinic don't want surgery, and 90% of people that I see, often we can manage with conservative treatment. But sometimes it helps to at least have an eye of what concerns me and what concerns a surgeon. Usually things such as spinal cord compression or neurological deficit, I usually get more concerned about. But fortunately, that's in the less common. I would also agree kind of with Dr. Sanfilippo was saying, along with women, in terms of osteoporosis and bone quality. That is something that can lead to fractures that can be presented with severe pain. In that same light, cancer care has drastically improved over the last year. So people with a known diagnosis of cancer, such as breast cancer, who all of a sudden now have debilitating, back pain or neck pain, particularly with movement or being upright, things that load the spine. That would also be something that I would recommend getting evaluated with, because that potentially could be some sort of spread of the cancer to the spine.
Let's take it back, or let's really start from the beginning, because I think we should just talk about when people hear back and people hear spine and they hear neurology. If somebody's like, is it my spine? Is it my back? Is the spine in the back? Is it my shoulder? Is it my head? Can you just talk a little bit about regarding people just how to approach what they're feeling?
So I can start off with that. I will tell you, there is actual, location of the pain. So whether or not that's in my neck, my shoulder, or is it my lower back, or is it my hip and buttock area, and what we call referred pain, meaning that you're feeling the pain in one area, but it may be coming from someplace else. I would tell you, so whether you're talking about back and neck or you're talking about spine, the answer is yes, that's all connected to the back and spinal area and is treated by any of the people you see on this video, or any people, whether it's an interventional pain management physician, a spine surgeon, a non-operative spine provider, a physical therapist. We treat all of those conditions. And the best part is we're used to, and I'll agree with Dr. Mueller, 90% of the people that we see don't ever need surgery. But we're used to seeing a patient, evaluating the patient, making that diagnosis of where it comes from. The neck and the shoulder, a lot of times there's a lot of crossover where I'll see a patient and it winds up being a rotator cuff injury that's causing their pain and not their neck. Or, someone will see a hip surgeon and it winds up that the hip is fine, but it's actually coming from the lower back. So I think the biggest thing is if there's something that is going on that's inhibiting you from performing your normal daily activities or your extracurricular activities to the level that you want to because of pain, because of dysfunction, get evaluated and have somebody sort of find out what that source is, what that diagnosis is, and then get you to the right person. So it's not a matter about, where you start is where you have to finish. It's, get started and get on that treatment pathway.
So we're going to talk about surgery, but let's start with physical therapy first. So Richard, because a question actually came in that said, what are some good things to regularly take care of your back? Is there specific exercises, stretching? Is it bad when you sit with your legs crossed? So I think that's kind of like in general, but then also I'm assuming as a physical therapist, you're seeing patients before they have surgery and then after they have surgery. So let's talk about the before surgery, because we're going to get into Dr. Mueller about what back surgery looks like. And then we're going to come back to you about like recovery physical therapy, but talk a little bit about what physical therapy looks like for somebody who's seeing you before they have to go to surgery and what that looks like. And then maybe in general, we could talk about some stretching and stuff. And I know we're going to do a live demonstration toward the end. So get excited. Don't log off early. You don't want to miss this.
So when we see a patient for physical therapy, they are generally referred by a physician with a diagnosis. The diagnosis could be spinal stenosis. It could be lumbar radiculopathy if they have symptoms that are referred down the leg. And we take that diagnosis and we try to formulate an idea of what those patients' impairments are. And then we look and see what is their history, what type of movement patterns or activities are they limited in, what type of movement patterns and activities are causing their pain. And then we do an examination to try to understand the nature of their pain and then put together a plan to try to address that.
And then if they're going through treatment and it's not getting better, then it's like, okay, off to the operating room you go.
Well, Dr. Sanfilippo and Mueller could weigh in on that, but generally, we try to make as much progress as we can, even if that means changing the plan of care frequently throughout the episode of care. And if we notice that a patient's pain isn't resolving, then we will refer back to the physician, and then the physician can make a determination on what they can do within their scope to help the patient.
So for somebody that may be experiencing like a little bit of back pain, it's not debilitating, it's just uncomfortable. What are your recommendations on maybe trying to do their own type of exercise to try to, I guess, is it evaluate themselves before they feel like the need to go in to see a doctor? Or is it maybe sometimes like it's an age thing, right? You're going about your life, you're doing what you're doing, then all of a sudden, you know, your back starts to hurt and you're like, what's this about? So some preventative measures that people can do almost.
Well, there are some preventative activities that you can do, some very simple exercises, which I will demonstrate later. But I think
don't give too much away.
But in general, I think a lot of people with back disorders and spine disorders, the problem stems from modern society and how we tend to be very sedentary. And that lack of movement tends to feed into these problems. So generally start by being active, be proactive about choosing an activity that you like to do that keeps you moving. If you have specific activities that you like doing, but you feel limited in, you feel like are feeding into your symptoms, that's probably a time that you would want to consult the doctor or come in and see a physical therapist. We can evaluate your condition. We can look into how you're moving and try to evaluate what your impairments are, and maybe even coach you into more efficient ways of moving. And then we could set you on a path where you're able to do your exercises more independently.
Yeah. So this is actually a really good question. Can poor habits cause pain in your back, like screen time or inactivity? My question is, can those poor habits of like sitting poorly or too much time, could that lead to then a more chronic condition, which then you may need surgery for?
I really do think that being sedentary feeds into a lot of dysfunction. But I think if we are able to kind of intervene early in the physical therapy world, we can probably prevent that surgery from taking place. If we get patients doing the right things and moving their bodies more efficiently, maybe avoiding the problematic postures or positions they find themselves in.
Yeah. All right, let's talk. Oh, go ahead.
I just wanted to expand on that a little bit too.
Yeah.
I think Richard's 100% correct with that. But then it becomes, to your point about can it lead to surgery? Well, I don't think necessarily that the sedentary portion leads to surgery, but then it becomes, and I'll use the phrase weekend warriors, but then you go to do something that is outside of your normal activity, and the joints, the discs, the bones, the muscles, the ligaments, the tendons, they're not used to doing those activities. That's when that injury occurs. That's when we see the disc herniation. That's when we see the compression fracture. That's when we see a fall cause an injury that it would have never caused before, because we're deconditioned, because we've been over sedentary and lack of movement and lack of flexibility. That can predispose you to an injury doing something that otherwise would not have caused an injury.
Right, that makes sense. So basically it almost develops a weakness. And what happens is you're weakening all the things that make you move, and that's what causes the injury that might need. And I mean, I guess there are some things that are genetic, that are hereditary, right? That there are people who just unfortunately have, you know, these issues with their back. And so they just have to monitor it more closely than a person who wouldn't, you know, their parent or their grandparent had something similar.
A lot of genetics plays a role into predisposing. Then it is up to the individual person, individual patient, you know, to monitor that or take the necessary precautions to stay active and prevent those types of things from happening if they can.
Yeah. All right, let's talk surgery, because it's important to actually talk about that. Spine surgery, back surgery, we're very grateful that we live in a space where we have this incredible medicine, that we now have people that could do this kind of stuff. So what does I think when people think, oh my God, I'm getting surgery on my spine, it seems debilitating, right? And I'm sure there are surgeries that are 14-hour surgeries and people are going to be in the hospital. And then there's also surgeries that are literally outpatient surgeries. And I think it's important to kind of explain a little bit just how vast surgery for back, neck, spine is in 2023.
Yeah, I mean, that is a lecture in and of itself.
You're like,
but,
that is what I did my thesis on.
But needless to say, the field of spine surgery has rapidly evolved, but has drastically evolved from its beginnings that were not too long ago in the mid 20th century. But you're quite right. Surgery, again, is the end of the road for a lot of these conservative care, and can take the shape of many different levels of invasiveness, depending on what your goal of the surgery is. I think it's also important to note that, yes, you talked about some of these surgeries being quite long, some be same day, but to the patient, there's still a surgery. And I think us as providers still, we treat that care of respect, though technically it may not be as challenging of surgery. It's still a surgery for that person. And that's a big deal, and that shouldn't be taken lightly. Certainly, techniques have improved and equipment has improved. Many surgeries now can be done less invasively, which is really about less collateral damage, not necessarily about the incision length, but less collateral damage, while still achieving the same goals of the operation of traditional spine surgery. Spine surgery, in addition to not only equipment and techniques, has undergone many of the stuff that we were talking about before with physical therapy in terms of surgery starts preoperatively, where in the people that are sedentary, oftentimes we will kind of get them going in physical therapy. We will do prehabilitation. We try to optimize their nutrition. In terms of post-operative recovery, we try to mobilize them early. We try to put them on a variety of medications that minimizes opioid use after surgery. So there's a lot of process problems that have been utilized to make spine surgery safer, to make it more durable, and to make patients at least recover faster and get back to recovery. But you're right, it could vary from same day surgeries to more extensive operations.
Yeah, I had two friends who had same day back surgery. I was like, oh, okay. I'm like, go science. Right. And they're like, they just like, it was like life changing. Right. So it is pretty incredible. So let's talk a little bit about pain management. Right. So I think something that because you brought up opioids, and I think that's really important because that's it's such a topic right now in regards to people just want to take medicine to kind of numb the pain. What is your advice on pain management before it's time to actually get surgery?
Well, so from my standpoint in my practice, I use pain management a lot, and for a variety of reasons, both diagnostic and therapeutic. Obviously, we want their patients to try and improve their function and quality of life through non-surgical means, but sometimes.
But then you won't have a job.
there's a lot of people in the world.
We don't want to give too many hints out, because they still want to stay employed.
But, for example, I very commonly see people that have had pain management, they've had injections, and it's treated as like a checkbox. I had injections and now they didn't work, and now I'm here to see a surgeon because I guess I have to have surgery. A very common thought. And one of the things that, pain management with injections can do, especially if they're having leg or neck pain or arm pain, is you, in addition to clinically trying to identify where that source of pain is, the injections can often do in a similar fashion. If they provide relief, that can give us as surgeons better understanding of what is their pain generator. Because like has been talked about before, there's pain, and then from the spine, from compression of nerves, there's referred pain from other joints, the shoulder, the hips. And so fundamentally, we are doing our best to localize where we feel that source of pain is coming from in that particular patient. That's
really, yeah, that's a really, really important note that I think everybody watching needs to take, that a lot of it is, I think, because a lot of people get frustrated. I know my dad needs a knee replacement, right? And like they've been doing one kind of shot and then another kind of shot, and it's frustrating. And I think people just immediately like, just give me the surgery. But as experts in your field, you're saying we actually need these steps before to figure out exactly what's going on.
Yeah, and I'll say 100%. You know, there's the line I like to use with patients all the time is we can always do surgery, we can't undo surgery. So I think, you know, to your point before, science, technology, medical techniques, all of this has led to huge advancements in these fields, especially in spine surgery over the last, 30, 40, 50 years. But it's still not without risk. And I think sometimes in our society today, we're just, okay, let's just fix it and move on. But sometimes those fixes come with risks. And we're very successful. Spine surgery today is much more successful than it's ever been. We've minimized the risks, but they're still there. And if you're one of those people that winds up with a complication or with an issue after surgery, you can't undo that procedure. So if we can get you better with physical therapy, if we can get you better with chiropractic or acupuncture care, if we can get you better with an injection, yes, we use it as diagnostic, and I do as well, and I think that's huge. But if we can get you better and get you functional with that's the home run. Surgery really, for the majority of spinal conditions, and there are a few that surgery is the most conservative care, meaning we need to do it. But for the vast majority of spinal issues, when those things fail, that's when it's worth taking that risk. So it's a lot of risk reward and balancing that out.
And sorry, go ahead.
I was going to say the other thing, you brought up narcotics. I think narcotics are an issue for a lot of reasons. We try to minimize narcotic use. And when Dr. Mueller was talking about pain management, he wasn't talking about narcotic medication. We try to minimize that because narcotics, number one, are going to make you more sedentary. So that's going to lead to a bigger issue. Number two, if you're on narcotics preoperatively, the more narcotics you're on, the harder it is to control your pain after surgery. The vast majority of patients that we see and we operate on that have been on very short length of narcotic or very small doses or no narcotics at all, those patients are on narcotics for less than a few weeks after spine surgery. Most spine surgeries, they're up the same day as spine surgery. A third of our procedures right now are performed either in an ASC or in a hospital outpatient setting, meaning they're coming in and going home the same day. Our length of stay right now in the Virtua system is less than 2 days for major spine procedures. But those are people that are coming in that don't require the narcotics as much, that the pain is under control by the time they go home, that we can mobilize early. So that's where, yes, we need them. They're a necessary medication and they do help, but they also need to be managed and minimized. And that's where a lot of our pain management techniques today and pain control techniques today don't rely solely on narcotics or even the majority on narcotic.
Right. We're going to go to Q&A in 1 second, but I do really want to talk about, because I think we've been talking about chronic pain or acute pain, but I think it's important to talk about, and Dr. Mueller, your specialty is in spine tumor. And so that is a whole other element of, if somebody has a tumor or if somebody has, that's not necessarily a chronic pain, right? That is something that you're immediately going to address. You might not put people through all these other steps because it's completely different than, let's say, a herniated disc, obviously.
Yeah, so there's different kind of conditions. The vast majority of conditions that we have all been talking about currently are degenerative, which is just wear and tear, arthritis. On top of that, you have a little bit more complex conditions, which involve a malalignment of the spine, such as scoliosis, and then when people have spine tumors. Tumors can be the range of benign tumors to more aggressive or malignant tumors. And they can occur in various different regions of the spine. And they can present with a variety of symptoms. They can be pain related. They can be neurological issues with numbness and tingling. And sometimes if there's severe neurological impairment that's present or threatened, then sometimes that's when more urgent intervention is needed. Sometimes tumors are found incidentally because of the fact that imaging is done quite readily nowadays, and we have such high definition imaging. We'll have a patient be seen, I see them in clinic, who was being worked up for back pain and incidentally was found to have this small lesion suggestive of a tumor. Sometimes we do the same thing. Most tumors in certain regions can be a benign pathology, although you won't know unless you actually diagnose them with tissue. However, there's sometimes we can look at the MRI and patient characteristics to get an idea of, is this going to be something more aggressive or something more benign. Sometimes we can actually biopsy these lesions, and then we would definitively know. But tumors span a whole gamut of benign conditions that occur in the spine bone itself that extend into the canal. Some occur in the actual spinal cord itself, and some occur just outside the spinal cord. I will say sometimes the ones that include the spinal cord itself, those patients they're often cited as being paralyzed by indecision. And the reason I say that is not literally paralyzed by indecision is because there's only a small handful of diagnoses that is. I have a couple of people in clinic this way, and they just have some arm numbness or leg numbness. But the surgery to remove that could actually significantly impair their motor function. And certainly we have ways that we can make it safer, but it's certainly not without risk. And so they're often deciding, is the surgery worth getting it out if it is going to be a benign condition, and take that risk versus just deal with some arm numbness or something like that. So it's certainly, with spine tumors, it's certainly a dedicated conversation with patients. And if need be, certainly conversations with oncologists and radiation oncologists. And we do this quite frequently with tumors of the brain as well.
Yeah, and I think that it's so important, as you can see, that we have at why Virtua is so expansive and so great at what they do, because you're starting in, you have physical therapy, you're doing pain management, you're doing everything from chronic conditions to it's important to, like you said, know your body and just go to the doctor first. And then there's all these outlets where you're going to actually take the time, get the imaging, talk to each different expert on what works for you. And like you said, you could think that it's one thing and it could be in another. And I know for some people that's scary, where they're like, oh, it's fine, it's just back pain. But when you have experts that literally dedicate their lives to trying to fix it, do yourself a service and go and get it checked out. All right, so okay, so Richard, are you ready for your debut?
Believe I'm ready.
Okay, so what we're going to do is, Richard is going to do some demonstration for us about really cool, some stretching and how we're going to feel better, right? Because we have been sitting a lot. Everybody's obsessed with their phone, all the things. And then we're going to do some Q&A because there's a lot of great questions coming in. So I think it's important to move ourselves, shake it off, get some stretched, and then we'll do, because So, all right, Richard, take it away. The stage is yours.
Okay, so first of all, give me some feedback if for some reason my demonstration area isn't clear, you're not seeing all parts of my body, but I do have a treatment table back here, and I'll be doing a couple things that I consider to be step number one with an acute injury. Let's say you have something that happened over the weekend, you bent over in your garden to pick up a stick, and suddenly you feel like your back went out. Maybe you even have some pain radiating down your leg. There are certain things you can do immediately to assess for their ability to really have a good impact on your pain. So the number one thing I would do in most situations is try to lay on your stomach. For some people, they feel like, hey, I don't feel comfortable in my stomach, but we can usually modify that in some way, maybe by putting a pillow under the patient's hips. So we take a little bit of the extension out of their spine, and it can be very comfortable for them. It can take away the local pain in the low back, and it might even centralize some pain that might be radiating into their leg. By centralize, I mean kind of move the pain away from like the buttock, the posterior thigh, or the calf, and move it up closer to the hip and the low back. So I'll demonstrate that.
Oh, I was gonna say, are you gonna demonstrate it? Because in yoga, it's called Superman, right? Where you're kind of like leaning and stretching.
Yeah, so before we even got that far, I would do something more basic position-wise, and I'll show that to you in just a second.
Okay, great.
You can see my treatment table, right?
Yep, perfect.
So I'm just gonna lay on my stomach. For a lot of people, this is first aid.
Oh, wow. Okay, that's awesome.
So if for some reason that is not tolerated, a pillow underneath the hips. And that can be more comfortable, especially in more acute situations.
And how long are you supposed to lay there?
I would say like 3 to 5 minutes.
24 hours.
Like 3 to 5 minutes at a time.
Okay.
When this becomes more comfortable, take this out. Okay. And then you can even go up onto your elbows. And that's going to promote more extension in your back. And I would say the caveat to all this is we want to make sure the pain is actually subsiding.
Yes.
And at the very least, the pain is more central in the low back and it's not traveling farther down the leg.
So let's talk about this really, really fast. So if somebody is gardening and all of a sudden they feel like their back, what is that? Is it a pinched nerve? Is it a muscle spasm? What exactly is happening to the person when that happens?
I think most likely it's compression of disc material.
Okay.
So we know that the discs are loaded more in a flexed position,
Got it.
especially
Okay.
being crouched down or leaning forward. So in physical therapy, we try to coach people to try to maintain a neutral spine when they're squatting and lifting things.
Mhm.
But if they're getting into a position where they're kind of squatting down like this with a flexed spine,
Bad.
that's a recipe for loading the discs.
Yeah.
And sometimes loading the disc will lead to a bulged disc or a herniation, which can only really be truly diagnosed through imaging. But in the physical therapy world, we kind of cluster these symptoms together and come up with a hypothesis of why a patient might be experiencing pain. So if they had a flexion-based injury, we would try to treat them with an extension-based exercise or movement pattern.
Makes sense. Do you have any other stretches for us?
Well, another one that I would do is primarily preventative.
Okay.
And it really assumes the patient's comfortable lying or not lying, but getting into a quadruped position, like hands and knees.
Yep.
And it's perfectly fine to do on a bed. So I'll show you that also. It's basically cat and camel or cat and cow. Okay?
Yeah.
Okay, so we're just dropping into extension and rising up into flexion. So that's your angry cat, and that's your cow. So if people can tolerate doing that, getting onto their hands and knees on their bed, and they do that like maybe 10 times a day, I think that can be preventative by maintaining the mobility of the spine.
Awesome. 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 All right, let's dive into some of the questions. So, what do the doctors prescribe for osteoporosis in the lower back and hips?
So a lot of times, if a patient has osteoporosis or they show up with a compression fracture from osteoporosis, we're probably not the ones that are going to treat that actual underlying source, which is the osteoporosis. Usually I defer to the primary care physicians, or I defer to the rheumatologists for that type of treatment. There's a lot of medications out there today, some that promote bone growth, some that prevent bone resorption. But most of those need to be monitored on a monthly or at least semi-monthly basis with lab work. And it's more, tends to lend itself more towards the primary care docs and the rheumatologists being treatment based and following those patients long-term.
Makes sense. So this is from Kate that says, when should you seek neurosurgery? Like if it's radiating electric pain?
Yeah, I mean, I think this goes back to the very beginning when Dr. Sanfilippo was talking about kind of factors that are concerning to at least be seen and evaluated. Certainly, shooting pain from the neck down the arm or from the back down the leg can be a lot of things. It could also be, compression of the nerves. And so, certainly having it being evaluated to see if it is coming from the spine, and if so, what that looks like, and that can help kind of as a starting point.
Do you send people to chiropractic care, and is that type of care considered more legit?
So I send people to all sorts of conservative care. I've sent people to physical therapy. If a patient is more comfortable with chiropractic care, I encourage chiropractic care, acupuncture, cupping, yoga, Pilates, water therapy, water aerobics. Really, there's a lot of different treatment options and pathways out there. Some people are more comfortable with traditional, what we call allopathic type treatments. Other people are much more comfortable with holistic. I had someone ask me today about acupuncture. I said it's been around for 5,000 years. It's had to have helped somebody in that time frame. If it helps you, great. That's all that matters. So I think there's a lot of great non-operative options, or what we typically refer to as conservative treatment options. And if there's something that you're doing, it's something that helps you, I continue doing it. Or if traditional techniques haven't helped, it's worth trying some of these holistic or the non-traditional medical techniques. As in anything, I will tell you, it's very much provider-based. There's some, you brought up legit. Is chiropractic legit? Chiropractic is extremely legitimate.
Vicks Pure Z's Kids helps your child fall asleep naturally. It's a low-dose melatonin gummy specially crafted for kids. Plus a complimentary blend of chamomile and lavender.
Sorry.
And nap.
There we go.
Okay.
One of my tabs playing in the background.
Oh, geez. It's very much provider based in any of these treatments that you seek, including surgical. If you feel comfortable with your provider and they're helping you, then I would definitely continue.
Yeah, because somebody also asked about dry needling. So that's the same. It's the same thing. Like, why not? Right.
Absolutely.
Yeah, I would agree with all that in terms of the conservative management. Max out all those opportunities. And the only caveat I tell people is it's just because I'm biased as a neurosurgeon, I see vertebral artery injuries from the chiropractor. So I just tend to not say any neck. But everything else, I try to do it, and I tell them I'm biased because if there are injuries, and fortunately they're few, but we tend to see them, so I tend to be biased by that.
Wait, so what is that? It tweaks your neck and then it hits an artery?
Yeah, in our necks, there's two arteries that supply the brain stem and the base of our brain, and they travel through these bony channels in our neck. And so if you have severe turning to the neck left or right, or severe rotational rapidly, sometimes that can cause a tear in the artery wall. And sometimes that can lead to strokes and dissections. So sometimes people can have genetic conditions that can make their arterial wall prone to this. But it's a very critical vascular structure. It's something we're all aware of when we're operating on the neck. But related to chiropractic care, that's why we sometimes see that with the neck. So that's why, from that aspect, I just will always be that, just as a neurosurgeon.
Yeah. Pain in the neck when waking up. Should you use a certain type of pillow, like a side sleeping pillow? Or maybe it's your spouse. Maybe they're the pain.
So, Rich.
Well, I see a lot of patients, and I make a lot of recommendations to try to minimize chronic strain on the neck while sleeping. I recommend a low profile pillow for most people. I have a pillow here. I'll show you what I would do to modify the pillow. I would just put a towel roll inside the pillow, and that supports the neck while you're sleeping. And it's able to keep your neck in a more neutral position. But I would not recommend having multiple pillows for most people, because that kind of puts your neck in a flexed position or a side bent position while you're sleeping.
And what about pillows for the back? A lot of people say sleeping with pillows between your legs could alleviate back pain. A lot of people say sleeping positions, you're not supposed to sleep on your stomach or your side, but it's hard to sleep on your back.
Well, sleeping on your back can be made comfortable if you have support underneath your knees.
Right.
If your legs are up on a wedge and your knees are supported, it can help your back stay in a neutral position while you're sleeping.
This is a really good question. How do you distinguish back pain from UTI versus arthritis in the spinal area?
Well, a lot of back pain in the lower lumbar spine, in the lower back area, is arthritic based. Whether we call it degenerative disc disease or the facet joints are the joints behind the spine, and whether we say that they're the source, that all sort of causes back pain, and they're degenerative conditions, which we lump into sort of arthritic conditions. I would tell you, UTI, if you're having any type of urinary frequency, urinary retention, fevers, abdominal pain, stomach pain on top of back pain, that's really where you start to get concerned about either an infection in the back or a UTI that could be causing those same types of symptoms.
Makes sense. How can you permanently straighten your spine and improve your posture over the age of 50?
People have a normal alignment that they're kind of born with. I think certainly sometimes they may have conditions that may alter their alignment. For example, if people have severe lumbar stenosis or just narrowing or compression of the nerves, they tend to lean forward or walk with a lean forward position. Some people call it a shopping cart sign. So that they lean as if they're pushing a shopping cart, so that the spinal canal has a little bit more room, so the nerves are a little bit more free. And that can be a source of posture issues. And then sometimes multiple level degenerative conditions or an underlying malalignment, such as a scoliosis, can contribute to a posture issue. So I think ultimately it depends on what that posture issue is, and ruling out if it's from an underlying spinal issue. If it's not, then potentially, I don't know if Rich has any issues in terms of strengthening the muscles, but that's what I would probably look for.
Let me jump in really quick, because this kind of to piggyback, but Rich, you can talk about this, but are devices to correct posture good to use? So obviously some people sit on, one of those big, not Bosu balls, but, like yoga balls, or there's obviously different chairs, different, does that help? Is it worth it? A lot of people are doing stand-in desks, or they're like walk-in desks now.
Well, in terms of positioning while sitting, I recommend something like this roll here.
Oh, okay.
This is called the original McKenzie lumbar roll, and it fits right behind the low back. I don't know if you'll be able to see this, but
Yeah, we can see it.
while you're sitting, it fits right in this space. So if you're tending to slouch while you're sitting, this will kind of support you and prevent that. So if you are a desk worker, I would recommend definitely getting something like this. Even if you don't get this, if you just use a towel roll behind your back, that can be a really good thing to support your back while you're sitting. But I would also recommend changing positions frequently. So having that standing desk and be able to move between a sitting and a standing position is a good thing to have.
Yeah. Somebody asked, is cat-cow okay to do if you have osteoporosis?
I would say it should be pretty safe because you're getting into a position where gravity's not acting directly in a compressive fashion on your spine. And generally, I would recommend for anyone, just do it within a comfortable range. So even if that range is small, don't push yourself into a lot of discomfort. Just make it small and then try to make the movement bigger as you tolerate.
I think that's really good advice too, because I think a lot of people just kind of go about their life, right? And then all of a sudden one day, like their back hurts or their neck hurts and they're like, whoa, how did this happen? And they're not used to doing stretching every day. They're not used to doing yoga or Pilates or any of that stuff. So it feels very overwhelming. So I think starting small, even just doing like deep breaths, even just like doing breaths and like just moving and like stretching your body. I think, like you said, small little things to get back into that mindset that actually movement really does help. And not feeling like overwhelmed by it. So, okay, it's crazy that it's almost time to wrap up. So I think it's important. So before we end, do each of you have one or two or three pieces of advice that you would give or a tip that you would like to share with our attendees?
I would say, go ahead,
Go ahead,
Dr. Mueller. Go ahead.
All right. I would just say that the vast majority of people suffering from these conditions is surgery should always be a last resort. And the only two times when I get that should raise concern is if there's some sort of neurological deficit, such as weakness or a spinal cord compression. I think that the vast majority of other ailments and conditions are usually driven by the patient and in collaboration with working with the surgeon and the healthcare team and managing those expectations. I think that surgery is performed safely these days, although it still has risk. But if you have a condition that is amenable to surgery and you've maximized everything, then I would strongly consider it to help improve your quality of life.
If you need surgery, this is like virtuous Patrick Dempsey right here.
Yeah, I would agree with Dr. Mueller just said about surgery and about seeking treatment and about the vast majority being non-operative. I would just encourage people as well, to stay active. We started to touch on it at the end. I'm a big proponent, if you're like me, I'll sit down at my desk and I'll blink and 2 hours, 3 hours have gone by. I encourage people all the time, set an alarm on your phone, every half hour, 45 minutes, get up, walk around, sit to stand desks have been a good adjunct to that, where at least you can change positions if you can't take an actual break. But stay active, get into some sort of low impact exercise program, continue doing your stretching and do the preventative stuff so that, hopefully you don't have to see me one day or Dr. Mueller one day. But the second what Dr. Mueller said, if you do, the vast majority of these conditions, are non-operative. And if it winds up being surgical, the techniques that we have today and the treatments we have today are so far ahead of where we were even 5 to 10 years ago.
Go medicine.
So piggybacking on what Dr. Sanfilippo said, I'm a big proponent of motion is lotion. So I really do encourage people to be active, choose activities that you like to do and do them. But if you find that those activities that you normally like to do are leading to some discomfort, or you just don't feel like you're able to participate at the level that you would like to, go see a physician. Ultimately, you might see me in physical therapy, and I will try to get you back to doing what you like to do, and do it in a safe, progressive manner that you can tolerate.
Awesome. Thank you so much. Thank you for participating. Thank you for your expertise. And it's your body. And if it's not functioning the way that you want it, there is help. If traditional remedies have been proven unsuccessful, it might be time to connect with a back pain specialist at Virtua Health. As you can see, there's a wide variety of experts and expertise at Virtua. Virtua takes a multidisciplinary approach to back pain with spine specialists from orthopedics to neurosurgeons to pain management to sports medicine, physical therapy, and more. For more information or to schedule an appointment with spine specialists at Virtua, just visit virtua.org/spine, virtua.org/spine. And as always, a recording of this session will be emailed to you in the next week. I know it's a lot of information. Sometimes it seems overwhelming, so it's emailed to you. And again, thank you so much. Thank you to our amazing experts for another terrific Real Talk session. Thanks, Virtua.